அமெரிக்க தொலைக்காட்சி நேயர்களுக்கு வணக்கம். நான் உங்கள் நிகழ்ச்சி தயாரிப்பாளர் ஷர்மிளா. கலைடாஸ்கோப்புக்குள் கண்ணாடி துண்டுகளை வைத்து குலுக்கி படம் பார்த்தவன் திரையரங்குகளுக்கு சென்று பெரிய திரைகளில் மட்டுமே படம் பார்த்து ரசித்தவன் இன்று கைபேசி வாயிலாகவே தனக்கான படங்களை தானே தயாரித்து வெளியிடும் அளவுக்கு விஞ்ஞானம் முன்னேறி இருக்கிறது. பலரும் இவ்வாறு முன்னேறியுள்ளார்கள். இவ்வாறாக யூடியூப் வாயிலாக பல்வேறு காணொளிகளை தயாரித்து பிரபலமானவர்களை அறிமுகப்படுத்தும் நிகழ்ச்சிதான் வைரல் வலைத்தளங்கள். இவ்வாறு பிரபலமானவர்களை நாம் சந்திக்க இருக்கிறோம். வாரந்தோறும் இந்த நிகழ்ச்சியை காண தவறாதீர்கள். தமிழ் அமெரிக்க தொலைக்காட்சியை சப்ஸ்கிரைப் செய்யுங்கள். நன்றி, வணக்கம்.
The meeting records.
Sure. Yeah, I'm going to start now.
Recording in progress.
Yeah, recording started.
Vanakkam. I am Dr. Saravanan Ramalingam. On behalf of American Tamil Medical Association, I welcome you, everyone. First of all, I'm very thankful to all the speakers and the viewers for your time. This is going to be a very interesting session. Without wasting any time, I give it to Dr. Mupana. She can take it from there. Thank you, Dr. Mupana.
Thank you, Dr. Saravanan. Good morning, everybody here in the US, and good evening for the viewers in India. So I first would like to thank American Tamil Medical Association and COVID-19 Tamil Task Team for giving me this opportunity, and Dr. Saravanan Ramalingam as well. Thank you so much. Today's topic is going to be on black fungus. We've done so many webinars all along, last year and this year as well. But today's topic is, we are hoping everybody, all of us can share the knowledge and educate ourselves and get more informed so we can help save lives. So I would first like to introduce the speakers. It's going to be the format this time. We've changed the format a little bit. We made it into a round table, so it'll be more interesting for everybody. And it's more like a question and answer session and with few case presentations. Anybody have any questions? Please post them in the chat box. After the presentations are done, we'll give an opportunity for you to ask the questions and get answers from the experts as well. So India has seen a lot of black fungus in the present time. It didn't happen last year during the previous wave, first wave. It happened now during the second wave. And we want to really lay focus on that. And we're waiting for Dr. Deepta to come back. But I would like to introduce Dr. Deepta. She's an internal medicine and infectious disease doctor. She's at Richmond University Medical Center in Staten Island, New York, USA. She's very passionate and she's very highly knowledgeable, brilliant, and she's so passionate. You can see the passion when she's talking and discussing points. We welcome Dr. Deepta Niranjalian. Our second speaker is Dr. Soumitra Shah. He's an MS and ENT surgeon. He's the director for Shruti ENT Hospital and Cochlear Implant Center, which is in Surat, Ahmedabad. He's also the winner of RAF Cooper Award. I asked him about his hobbies. He said he's a very ardent lover of cricket, and he started running these days as well. Our next speaker is Dr. Nehal Patel. He's an MDS. He's an oral and maxillofacial surgeon, and he did his fellowship in cleft and craniofacial surgery, TMJ arthroscopy, and total joint replacement. He's the director for the ABMSS cleft palate project, which is in Surat again. I would like to thank Dr. Dinesh Patel for giving me the leads and introducing Dr. Shah and Dr. Patel to this platform. Thank you. Thank you. Dr. Deepta?
Hi, good morning, everybody.
Awesome.
I have a little technical difficulties. Hope you can all hear me well. Can you?
Yes.
Okay.
I think you have two devices.
Okay, I'm going to shut off one device
Just the
because
audio.
I was on the, I'm trying to figure out which one to go on. How is it going now? Okay, let me get out of the Zoom. Leave.
My first question is for Dr. Deepta. What is this black fungus? Why is it called black? And what is this fungus all about?
Okay, I'm going to ask Prem to put my first slides on. While he's getting that, I just want to tell everybody, thank you very much for inviting me to the Atma Global meeting. And thank you, Dr. Mupana. You've been tirelessly working on getting this done. So, Prem, you have to go to the first set of slides. This is the last one. No. Oh, the first one I sent you. Anyway, why is it called black fungus? First of all, it is not black. The fungus is not black in color. And it is a fungus which is commonly seen. It is the mold which you see growing on the vegetables, and the furry little thing you see on the fruits, vegetables, all the leftover food, and also seen everywhere, dust, walls, wet area. And it is symbiotic with us. That means it's been living in the environment with us. We live with it. And this does not affect us normally. And Prem, you can take the slide off, please, because it's the last slide. And unfortunately, with the advent of medicine over the years, where we have learned to control diseases with suppressing our immune system. And that is one of the reasons where these kind of fungus and other viruses and other things which normally live with us become opportunistic. One condition in which our immune system gets depressed and our white cells don't function very well is diabetic. When you have a very high sugar, diabetic ketoacidosis, or hyperosmolar coma, when the glucose level is very high, persistently over a period of time, the mobility of neutrophils and T cells get suppressed. That is why we call diabetes as a slightly immunosuppressed condition, or what we call compromised in that area. Otherwise, diabetes, when it's well controlled, it is all right. Another thing about diabetes is in peripheral areas, that is in arteries and everything, they get thickened, you may have less blood supply. So what we are seeing at this point is the fungus invades the local area, and it has a affinity, or it likes to invade the blood cells, the arterial cells. So it cuts off the blood supply to that area, and as it proliferates in the dead tissue looks black. So it usually, initially, if we can pick it up earlier, it will be just swelling. then you will see redness, but it quickly spreads. So that is why you get the black. Black is just necrotic tissue. In medical terms, we say HR, and that is what it is. But it's really not a fungus which is black. There are other varieties. Mucor is a big group of funguses. And in that, what we tend to see in this particular area are Obsidia and Rhizophus and Cunninghamella. Just want to throw in the words for the people who are interested in microbiology. And what is the difference between mucor is for the pathologist, the mucormycosis and the aspergillus are the ones which they have to make a differentiation. And aspergillus has a beautiful 45-degree angle branching, whereas mucor is, can you go to the next one? This is where it looks. This will be what it will grow in a plate. In the culture, it will make these spores and the conidia. From there, the spores coming. This is what happens when you see a mold. And these spores are floating around. You inhale it, or you can ingest it, or they can go through a cut in a skin. So those are the areas you get it. Can I have the next one? Let's see, what do we have next? I told you about this one. The third, fourth one. This is what I mentioned to you. It causes the invasion of the blood vessels, causes thrombosis, and causes tissue necrosis. And in my close to more than 40 years, I have seen only 3 mucormycosis cases, all in diabetic ketoacidosis patient. Our transplant, my access to transplant was less in the last 15 years, transplant patients, so I did not see them. And the hospital where I worked did not have a bone marrow transplant. That is where they get it. The way I used to see them is diabetic ketoacidosis patient in ICU, where the sugars were somewhat there when all of a sudden the glucose gets out of control and their acidosis gets out of control. And they will have spiking temperatures. And the resident will call, doctor, the right eye patient complains pain. Usually I go in. Since they are in ICU, most of the diabetic patients was uncontrolled who are maintained on insulin, or they're coming in, they are in ICU. There's a lot of attention paid to it. And you will see that, or if you open the mouth and examine, you will see black spots. And usually we'll call the ENT and the oral surgeon, they're coming. And if you pick them up early enough, you could preserve some of the eyesight. But unfortunately, most of the time, the invasiveness is quite aggressive. And with that, I'm going to stop because you will have a lot more people. I do want to tell you one thing. The amount of cases or amount of patients being affected in India with COVID, with mucormycosis, is something which is phenomenal. The world has not seen that many cases in a short period of time. So this is something which is unusual. It was combination of probably multiple things, COVID itself causing thrombotic disease, and then immunosuppressive disease, all of that put together. So the world is actually looking at India and the Indian physicians and the surgeons to write a new chapter on this aggressive mucormycosis, which is seen in this era. As you can talk, even I was listening to Dr. Fauci, even he said in his entire ID career, he has seen 3 or 4. Most of us will see, if you're in transplant area, you may see at the most 10 cases. But that's about it. So I really have to defer to the specialists who are now in India. And the unfortunate thing about this disease is, just like COVID, the treatment is very difficult, hard to come by, and intravenous. You need a combination of diagnosis, good surgeons, good physicians, and availability of medicine, aggressive treatment. So the combination is rather hard in peripheral hospitals as well as in villages. So it is a rapidly progressive disease which causes, along with underlying disease, sepsis. and patients, we lose them. Hope with the drop in COVID cases and with the drop in immunosuppression, steroids, control of glucose, we'll see the other end of it. So I'm going to defer to the rest of the people to talk, and then I can come back for questions.
Sure. Thank you. Thank you, Dr. Deepta. I had one more question. So if you can tell us in brief, why not last year? That's the first time we got the COVID itself, right? The first wave. Why didn't this happen last year? Why is it happen now?
Good question. In fact, you can ask the same thing. Why not in USA? Because we are using the same high-dose steroids and also immunomodulator, tocilizumab, and all of the stuff. Why not? I really don't understand what is that. Maybe, I think it's a guess. I'm going on a limb. I wonder the variant in India has more aggressive invasiveness to the vascular epithelium. And that may be the one thing. But I don't really think we can say to some degree the environment, because there are people in this country who live in rural environment and they come to the hospital and they are in there. So it is a conundrum. We can blame a little bit of steroids, but people have been taking high dose steroids for years and years. I mean, you and I have seen people coming into emergency room with 400 and they don't even know they have diabetes. So, and how many people we've seen with DKA and they don't even know they have it. They walk in and then you find acidosis. There must be a combination. Either the virus, every virus causes some immunosuppressions to start with. They do suppress your white cells. So the combination of the virus, made something in the virus, or other thing is the uncontrolled diabetes, which makes it the predominant. Maybe the trauma, which causes it for it to penetrate. As I said, maybe the environment. People have suggested maybe this unsterile water and things like that. I'm really looking forward for the physicians in India to come up with an answer, because this is, as I said, we are all stunned and we are looking at it and say, my God, we had so many patients in Texas, in Florida. Remember the time their ICU was full? And these are all arid areas. And we didn't see that. And we saw a lot of candida superinfection because of antibiotic therapy and steroid. Occasionally, case of aspergillosis, maybe a case reported of mucor. It is puzzling. But one thing I can ask is, be careful of the steroid use, or use it appropriately. Monitor the sugar, aggressively treat diabetes with insulin. But waiting for the India to give us the answer on this one.
So I did my fellowship for pump critical care at Sloan and Cornell, and we used to do a lot of bone marrow transplant patients. We used to have them. But during my fellowship, I saw only 3 cases of mucor, and mainly in the lung. We do a bronchoscopy and then we find the mucor in the lung. That's been my limited experience with mucor. So thank you. Thank you very much, Dr. Deepta. Dr. Shah, moving on, I have a question for you. One of the questions is, why do you think you see a surge of these cases in India now? And I know it's coming, like Ahmedabad was affected first with COVID this time during second wave, and Maharashtra. Do you think there's a lag, there's a time sequence? And why do we think we're seeing so many cases?
Oh, we actually are surprised. We don't know. We're used to seeing a couple of cases a year of mucor, as Dr. Deepta said, because patients are immunocompromised with transplants. But it's been overwhelming. Probably 2 factors here. Most of these patients' diabetes are shot over the roof. They have had sugars which are 400 or 500. They've been put on a lot of steroids, judiciously or injudiciously, is something which I'll not comment on. But if you see we've treated more than 60 patients between me and Dr. Nehal, and even if they are young, or even if they were not diabetic, pre-COVID, if you look at their HbA1c levels, they are more than 10. When they come to us, their HbA1c levels are 10, 11, or 12. So that's been the most significant factor that we've seen in patients who we've seen with mucus. So they all have been diabetic. All of them have had high sugar levels. And that's probably the only single point I can give you right now. Maybe 6 months down the line, we'll have something on the strain, and probably the strain was more aggressive, but that's something for physicians to answer when they research it.
Thank you. Thank you. How many cases have you seen so far?
More than 60 now between the two of us.
Between the two of you, yes. What are the main symptoms, signs and symptoms they come to you?
So it could be as trivial as a small headache or facial numbness, but the general red flag signs are headache, post-COVID headaches, post-COVID bleeding from the nose, tingling numbness in the jaw area, loose teeth, pain in the teeth. These are the 5 red flags that we give our patients, that if you have any of these post-COVID, please go and consult a doctor and get yourself imaged.
Okay. Could you share a couple of cases that you've seen, please?
We made a spectrum of 5 cases, right from the patients who came to us very initially to the more advanced ones. Prem, can you put in a case studies, please?
So
Yeah,
we'll
sure,
do
doctor. Yeah.
one case at a time.
Yeah.
That'll be so helpful for all of us
Yeah.
to learn from that case. Yeah.
Next one. So this is actually a case we just did today. She's 24 years old. She has a history of COVID around 25th April. She was positive on 25th April. She was not hospitalized. She's non-diabetic. Her lung involvement was about 2%. And she came to me a week back with headache and facial numbness. Can you have the next slide, please? So we got a scan done last week, which suggested sinusitis in the left maxilla. If you can see on the scene, I put in an arrow there. And we did advise her to go for surgery. It's on that day itself. We said, you don't need antifungals as of now, just get surgery. For some reasons, they didn't come back, came back to us 2 days prior with an MRI, with the MRI showing retroantral invasion. And so we operated her today morning. Next, please. This was the endoscopic picture.
One moment. Prem, can you go back to the endoscopic picture?
Yeah, just pause there. So this was the endoscopic picture. We did a normal, basic, functional endoscopic sinus surgery. Dr. Nehal came in and put in a window in the maxilla. We've cleared her disease completely. We put her on amphotericin. We'll wait for her histopath report to come. But I don't see her taking amphotericin for more than 5 days, because this is very, very limited. Limited
case. So
very limited.
The normality here. Could you just explain to us, because we have audience from the community as well?
But so this is a left nose endoscopic picture. What you see, this yellowish black thing, this is fungus. So this is probably the area on the right will be where the maxilla is, the maxillary sinus, and this is where the entire disease is. So what we've really seen in the pathophysiology is that the disease starts in the nose, starts spreading to your maxillary sinus, and then if people do not get treatment or do not come in time because of the sugar levels or because of the immunocompromised state, the disease starts spreading. It will start spreading first to the alveolus and the jaw. It will start spreading through the inferior orbital fissure to the orbit. And once it goes to the orbit, then the potential door to involvement of the brain opens up. So it's completely dependent on when these patients turn up with their symptoms to us and when we image them. But this is probably one of our very few patients this is very, very limited disease according to us. We are very happy if she's come at this time, because very sure that she'll be absolutely fine.
Thank you. Thank you. Next slide, Dr. Shah.
Yeah.
Thank you.
Next frame, please. So this is a lady who was 65 years old. She was diabetic. She had COVID 3 weeks back before she came to us with 75% lung involvement. Main complaints were facial numbness, cheek swelling. Can you get the next slide, please? If you look at an MRI here, again, I'll put an arrow. It's a right-sided disease in the maxilla with breach of the infraorbital, the margins of the orbit there. She was heavily diabetic when she came to us at HB1. She was 12. So we couldn't really go in and jump in and operate these patients. So we admit them. We have a team here. So the team involves me as an ENT surgeon. It involves Dr. Nehal Patel as a maxillofacial surgeon. We have a physician who takes care of the diabetes. We have an infectious disease specialist who comes in and takes care of the doses for the amphotericin. And we also have a nephrologist and ophthalmologist on hand for the cases where we require their expertise. So I think by the time we got our diabetes controlled, it was 5 days, but the facial swelling started reducing. What we've seen is once we put them on this on the amphotericin infusions, the disease starts limiting. So the spread stops. So we're not really worried about the disease going to the orbit or to the brain because we've already put them on treatment. So 5 days later, we operated her. Next slide, please. Next. So this is again an endoscopic picture of the right maxillary sinus at the suction showing you that fungus. That tissue there is not normal mucosa, it is fungus. So this was the fungus in the sinus. So I generally use an endoscope and do the clearance to the nose, and then Dr. Nehal Patel comes in and puts in a window through the maxilla. Next, please. So this was the clearance, or the picture on the upper right left is the endoscopic view of the maxilla, completely cleared. The picture below is of Dr. Nehal, who will comment on that, where he's put in a window and checked the alveolar region to make sure that the entire fungus has been removed. Because what we've also seen is we've seen patients who've come to us who've been operated elsewhere, who've taken amphotericin, but then have had residual disease, and that disease lies in the alveolar area. For us as ENT surgeons, we have limited access to the alveolus. So that's why we always make sure that the maxillofacial surgeon comes in and puts in a window and checks. And I want Nehal to comment on that slide, please.
Sure.
Yeah, so thank you. The reason we started doing is in our initial cases, what we have realized is, I think I have one case which is very interesting, which I'll talk about. But the reason we started doing is it is an invasive fungus, and initial stage when you see on the MRI, you may see there is a little bit of marrow edema just below the apex of the sinus, that is near the canine and premolar area. Now that marrow edema, it is like an invasion of the fungus, and if we don't check that area, it may later on come with the completely osteomyelitic alveolus, or maybe they involve the entire maxilla. That's the reason after 3-4 cases, what we have seen, I started. So once Dr. Soumitra does his endoscopy in, he calls me, he said, I think you better put a window there and remove and check inside and scrap the bone on the floor of the sinus so that there is no residual disease. And that's the reason we started. And in couple of cases, we have removed the bone, which is, we usually send a separate biopsy for histopathology. Like whenever he removes the lining, so he will send from the frontal bone separately, ethmoid, sphenoid, left and right. Same way, when I make this window, I send this bone as well as the lining, which I removed, and we write this open surgery. So what in 3 of the cases, what we have realized is the bone window, the bone which we sent for actually histopatho, it came as a positive for mucor. That means the mucor has already invaded that particular area. And that's the reason we started doing like this. I have a very good case in the next slide, I think, that we can discuss.
Sure.
So the idea always has been that we provide these patients the maximum of treatment and make sure they do not have recurrence, because that is the priority. So yes, we get a little aggressive in terms of our treatment, maybe, and some people might say that, but probably with the kind of disease and the kind of epidemic we are seeing right now with mucor, I would rather be a bit more aggressive than regret later because the patient then lost his eye or jaw. So it makes sense to be a little more aggressive right now.
So, Dr. Patel, I have a quick question.
Yeah.
You do the window, right? Is the window a permanent one? Do you leave it like that?
Yeah, it is like a cardioid approach. So that small window remains there. It usually covers with the, but as Dr. Soumitra said, what we have realized it is better to make a small window rather than getting that patient back with the recurrence which entire jaw is involved. So in the single sitting, when he does his endoscopy, I just make a small window and see. Now, if you look at this case, this very interesting case. This is a 28-year-old guy who came with the complaint of severe one side, left side of the jaw pain and pain in the tooth. So we just took a CT scan, and then looking at the CT scan, I thought it is just a simple sinusitis. It is involving the left side. If there was no history of COVID, I think Dr. Samudra would have treated as a bacterial sinusitis rather than considering it as a fungal sinusitis. So if you look at the scan, there is only one area where you can see there is a collection of the fluid. And can you put a next slide? Next slide, please.
You click. Keep going, Prem.
No, I think you have gone too far. Can you just come back? Still? No, you have to go back. You are going. I just want to show the MRI. Yeah, just one more back. Yeah.
No. Forward.
Yeah, next. Forward. Yeah, one more forward.
Next
I
slide.
think it's not got
Yeah,
that.
one more.
I think this is the
No,
slide.
it's okay. No, I just want to show that MRI. Just go back. No. You have skipped that MRI picture actually. There is an MRI there. That's important to show actually.
Actually, this thing I'm having, let me go. So this is slide 10, slide 12.
No, just before this one, there is an MRI. It just skipped past. Go
Okay.
reverse.
Actually, I'm getting blank screen. So this is slide
Just
number.
one more. Yeah, that's it. Yes. Hold on. This is the slide I want to discuss.
Yep.
So there is one MRI slide which was there, but it's okay. So when we saw the MRI, if you can see where I put my arrow, you can see there is a marrow edema. I mean, it is the apex of the maxillary sinus, and if you consider that molar tooth has 3 roots, and in between that a change in the bone consistency. Now, as Dr. Rita already said, that it causes necrosis. Now, to see that necrosis on the CT scan, it may take, say, around 15 days because demineralization of the bone, it takes some time to show actual on the CT scan. So we have to catch disease when it is initiating in the bone. So this is where you can catch on the MRI. You can see a little bit of marrow edema, and when we see that, Dr. Soumitra usually asks me to open a small flap on the tooth. Can you go now? Next slide, please.
Next.
Yeah, next. Just, yeah, so hold on. So when I open this patient, you can, no. Okay. So this is the bone. You will see that cortical bone is absolutely healthy. And when I saw that, I just removed the small piece of bone from the premolar area. You can see that there is a small ditch which is made from the apex of the. I felt little weird about that bone, and I decided to take out one tooth, only one tooth with the due consent. I already informed the patient that if I require, I'll take out your one tooth to see the consistency of bone inside your socket. Press next.
Next.
So when I remove that tooth, if you see that socket, there is no bleeding from the socket. And this is the area, just hold on. So this is the area from where the disease started invading the bone. So in spite of there was no sign of disease in any other sinus except for the left maxilla, in spite of there was no bony invasion showing on the CT scan. That is because it takes some time to show on the CT scan. we decided to start taking out this tooth. And if you see there is a necrosis which is started. I mean, it is just an invasion. The cortical bone is not necrosed. The marrow part which contains the fat, and that's where the mucus start invading itself. Just go next. So I started removing one by one tooth, and you see there is third tooth. There is no bleeding. Next. And if you see this picture, you will see that there is a bleeding socket when I removed one incisor. That's where we stop. That's where the disease is not there. So then we make a cut. It is better to remove that allulus rather than allowing it to progress in somewhere else. And this is the cut we make. And so we remove the allulus completely till there is a bleeding bone. Next. Just hold on. Yeah, this is the, just hold on this slide. So when I removed that entire segment which was necrosed, what I realized is, you can see here, just above the molar tooth, the bone marrow which is lying there, it doesn't look good. It is black out. I mean, it started off necrosis in spite of the entire lining was removed. And this is where we cut that tooth along with the bone. Next. And that's where you can see there is one side of the socket which is black, and other side where actually there is a bleeding points. Next. So it is like when this is a specimen. Next. And you can see here that there is a healthy bleeding bone now. So this is where we work together. Like whenever he does the endoscopy, we try to catch the things in the initial state. So in spite of there was no sign of any necrosis on the CT scan, just small marrow edema, if you have seen that entire one side of the maxillary allulus is started getting necrosis or thrombus, and that the part we remove that, now there is a healthy bone, so that's where the amphotericin can reach there. It is like if the bone is necrosed, the antifungal drug is not going to reach, and then we usually close it primarily. Next slide, please. So there is a less of the morbidity, and patient is virtually disease free. This is how we close it. Thanks. This is an interesting case to show. That's why we put this case, because this is the very beginning. I mean, this is the initiation of the disease. That's why we actually caught it and removed the disease. Thank you.
Thank you, Dr. Soumitra and Dr. Patel. I think that was very interesting. I know we have people from the community as well, non-physicians. So if any one of you gets scared seeing blood, please turn away from the screen, just momentarily. And can we move on to the next patient? I think you had a couple of more patients.
So yeah, this was again a 50-year-old female, COVID 1 month back, diabetic, hypertensive, 50% lung involvements. She came to us with facial swelling, periorbital ecchymosis, watery eyes. Next, please. The CT scan, again, she had diffuse disease in the frontal, maxilla, sphenoid, and the ethmoids. If you look at the right side in that arrow, if you can make out, there's already erosion of the orbits there. There was erosion of the orbital wall. We call it the lamina patracia. So there was erosion of that. Again, we couldn't post up for surgery immediately. High sugar levels. She was breathless. Put her on amphotericin. 5th day, 6th day, operated her. Next, please.
So the white tissue there is the fungus.
Next slide. Okay, this was an previous, please. So this was an endoscopic picture. Again, you could see this is the right side. This is just the middle turbinate and the nose. You can see fungus here. Next, we drained all the sinuses, did a complete radical endoscopic sinus surgery. This is a video frame been played. Can you play that?
Yep. Let me play the video now.
Yeah. It's 17 seconds, very small. Yeah, so again, if you see, it's a complete clearance. That's the orbits there. That's the frontal sinus on the front. So what we try and do is then remove every bit of mucosa, completely decompress the orbit, and make the entire cavity big so that the amphotericin can then penetrate. What our entire protocol also, what we do is we put in a amphotericin soaked sponge inside the nose, which we keep for 72 hours to allow the amphotericin to penetrate in the bone. She's fine. She's now on her 15th day of amphotericin. Her report came out to be mucormycosis. She's gone home. She's healthy. Her swelling's gone. Her vision is absolutely normal, and she should be fine. So we see all kinds of patients, but we're very happy that again she came at a time when the orbit could be safe. So again, no jaw was removed, no orbit was removed, nothing was removed. Simple surgery done over an hour. Stayed in the hospital for 6 days, but she's healthy and fine now.
So, Dr. Soumitra, I have a question for you. Does this patient need amphotericin?
Yes, ma'am. Her histopathology report did come as mucormycosis. So what we do is, as I told you, there's no just one way to treat these patients. They need amphotericin. They need medical care for the diabetes and to check the kidney functions. But you also have to go in and remove all necrosed tissue. If you don't remove the necrosed dead tissue, none of your therapies are going to work in the long run, because eventually when you stop the amphotericin, the disease is going to come back through that bone or through that mucosa where the fungus is lying. So you need to go in and remove that.
Remove that, okay. Yeah. So what I'm hearing is the most important point is recurrence. That's why you're being, I wouldn't say aggressive, that's why you're being really proactive in removing all the tissue which you think could be involved and taking it out. And then following it up with the liposomal amphotericin B, so they can get treatment and the recurrence is avoided, right? Okay, thank you.
Dr. Mupana, can I just say something here?
Of course.
It is interesting, he mentioned local amphotericin B, because that is one of the things we had used years ago before fluconazole, others came along, for candida cystitis. And because all candida in the kidney, we used to have infusion of the amphotericin B in the bladder and stay on and let it open, because you can get a little higher concentration and it will penetrate locally into the tissue, and the contact with amphotericin B seems to work better in this invasive tissue where there is compromise of the tissue and there is, the penetration of the amphotericin B through IV. When you give intravenously amphotericin B, by the time you get blood levels and then gets into tissue, especially in areas where there's vast compromise, it is difficult. So it is interesting how they use the amphotericin B locally, which I think is a very novel way to handle the disease, because after they do the eradication, there's still probably some fungus left. So that can be treated, especially with the new cuts and open area. And I think this may eventually become, I guess, one way of looking at treatment for early cases and then plan for surgery or whatnot. That one question I have for both the physician is that you seem to be having a lot of younger people, and also, as I was looking through, there are two similarities: is the osteonecrosis, the ischemia of the bone, osteonecrosis. What we tend to see with some of those calcium deposit medications we use for osteoporosis, I tend to see them. Again, there also is the differential diagnosis between osteonecrosis versus infection. So would you say, Dr. Nehal, that the source of infection could be from the molar area with the infection from outside going through the bone into the sinuses, or it is from the sinuses the other way around? Because for it to invade into bone and to cause ischemia of the bone, or the ischemia came first, then the bone infection. I mean, the question is, which way is it going, up and down? And the second question is, uniqueness about Indian treatment of COVID is inhalation. And cleaning as a part of our yoga and other things, people have a tendency to clean the sinuses. They put water on one side, they get the water out and all that stuff, through the one side, and they clean the sinuses. So do you think the rapidity in which this inhalation therapy, which is going on everywhere, as well as this cleaning out of the sinuses, do they have any contribution to it? Because it is not done in any other. Inhalation therapy is to prevent COVID is not something that common in other countries. So just had the question for both of them. Thank you.
Yes. So I'll answer your first question. So there are two types of bone necrosis what we are looking at right now. The one is what I showed you is very early. That is, it was not completely necrosed, but it was started to getting thrombus, and then it started getting necrosed. So this is the source from basically sinus, where the sinus lining is a line on the top of the bone. I mean, just above the alveolus. So since it is an invasive mucormycosis, in the initial stage of the disease, it may invade the bone, which is medullary bone in between the roots, and once the process starts, it start involving the other bone also. The second variant is we have a secondary infection on the top of the mucormycosis. That is maybe the bacterial infection. So when I see a patient, sometimes say patient has received the complete surgical treatment, they have completed their medical treatment, but after 2 months of the treatment, they come with the mobile maxilla. And when we do that, it comes to the bacterial osteomyelitis rather than a mucor. So these are two variants we are seeing right now. And the mucor case is what just now I presented, that is a pure mucor. So I think it is coming from the maxillary sinus to the medullary cavity rather than going from outside to the bone. And for the, this is second wave, we have seen the maximum number. There were few of the cases which reported in the first wave also, but those are, what I saw was very extensive cases, maybe undiagnosed. So we had around 28 cases from last July to 4th of the April, 28 cases, but those were very extensive, they reported late. What was the second question, ma'am? Sorry.
About the steam inhalation.
Yeah. So what we have noticed, me and Dr. Soumitra, is that most of the patients who are coming, they usually practice that steam inhalation. So we are not sure about the spread or the humidification of the nasal cavity, but that's where we stop. We ask them to stop doing that. So maybe that may be one of the reason it is more rampant in India. What do you say, Dr. Soumitra?
I don't know, ma'am, but see, it's been 14 months since we started seeing COVID in our part of the world, and every day I see patients who are doing inhalations, who are having this something called as kara or something, whatever they call it, which is warm water. So most of our OPD has patients who have burnt pharynx and larynx because of that, people who have crusting in the nose because of the inhalations, people who have not been COVID also. So I mean, I've had my fair share of patients who have been inhaling for 14 months but have not got mucor. And we've had patients with COVID who've got mucor. So I can't really pinpoint, but we definitely encourage people not to do it. I mean, you do steam inhalation once a day, fair enough, but there are people who do it every 4 hours, which I don't know. I mean, I would rather wait to give comments before some thesis comes out on this. But I said, we have patients with inhalations who got mucor, but there are so many on the flip side who've been inhaling for 14 months who have got nothing. So can't really pinpoint on that. Probably diabetes, high sugar levels, steroids, two things. This is two things which have always come to my mind in this 60 odd patients that we've seen. Maybe they may be young or old. But as I said, all of them have had HbA1c levels which are high. All of them have had IV steroids. They have been given steroids prescribed at home post-discharge from COVID. So these two factors have been significant. The other things, maybe they are relevant, but I am not in a position to comment about it right now.
Right. So I've seen recently, 4 days ago, I saw a patient and 60 years old, no diabetes at all, previously noted, and had COVID. 6 weeks later, after post-COVID, started developing, just like your case, patient pain, and he had some swelling here, and he was diagnosed. I mean, they thought it was mucor, and he was sent from Vizag. He was sent to Hyderabad actually for further ENT evaluation and the AMPO treatment. So even in non-diabetic patients, if they've had COVID, because of the inflammatory process itself, it can hike up their sugars. And in addition to that, getting doses of steroids, heavy doses of steroids, can make it things worse in terms of sugar levels for them. I think that's a setting for mucormycosis. So we do have to be careful about that. So what we are learning from this particular patient is diabetic patients post-COVID and who've had good amount of lung involvement, symptoms, just like, because we have audience are also a community, so they can have headache, they can have facial pain, they can have watery eyes. Early intervention, early diagnosis is really important. So it's really important to suspect it early. As long as you're able to suspect and pick up the signs, call your doctor, then be referred to an ENT doctor like Dr. Shah, but he practices in Surat. And I think that those are the most important things to keep in mind. Thank you. So
I have one question, Dr. Saraswati. Can I? So I have a question for both of you and Dr. Deepta, that we have come across the literature which says the statin, which is been used to lowering the cholesterol, it is known to break down the mucor, and in Western country it is very widely used. And I asked one of my physicians, they said we conservatively use the statin for the treatment for, say, cholesterol or maybe lowering the lipids. So do you think that use of statin, which is widely used in Western countries, is one of the reasons? Because there is a literature which says the statin is known to break down the mucor. It is one of. Do you think that's maybe one of the reasons that you don't see those number of mucors in a second wave in a Western country than in India? I mean, this is just my question, which I think as a surgeon I could not find out, but as a physician, maybe you could answer this.
I have to say that probably not, because the fat, the statins, the fat in the fungus and the fat in the human our bodies are different. I'm not sure about the statin activity. The statins have had some activity in a lot of different areas. You know, we are coming in with that. But as far as I know, that some of the patients who have had mucor had never been on statin. They are just the phenomenon of statin, and everybody has only started in the last 10, 15 years. But the mucormycosis has been around. Rhinocerebral mucormycosis has been around for a long period of time. Even, you know, when I was a fellow, I've seen, which is about, I don't want to say many years ago. So I'm not sure about that. But at the same token, statin has been also shown to have immunosuppression. Because if you see that some people get herpes zoster while on statin. So we're not sure about what happens with statin. So I have to say that, you know, unless we really look at it on a controlled, comparing patients with the regular controls, I won't be able to say anything. But what I just was looking at is to see whether a bunch of things which is striking is most of the patients which you have mucormycosis all seem to have a very high hemoglobin A1C. That means that they've had hyperglycemia for a period of time. So I think in my mind, what comes to me is they are probably or borderline hyper diabetic or pre-diabetic SAD. Maybe with the COVID infection, with the stress. Another thing is the stress of this whole episode of what's happening and the COVID infection, as well as a mild myocardial infection in their sinuses, probably tips them further on to have them for a period of time. And then by the time they come to you, they have such high hemoglobin A1C. So as I had mentioned in one of the previous I think last week, somebody talked about the black fungus. The central point is that everybody who has a fever and they are being tested for COVID, probably in addition to all the others, should probably get a hemoglobin A1C and should get a fasting glucose. Because we are, at this point, we might do an RT-PCR, but I think the next level is maybe consider that. And even otherwise, if they are pre-diabetic, they need to take care of it. And all the diabetics have to probably follow their glucose quite carefully and vigorously when they are on steroids, and start using insulin. Right. That is the only way you can bring these hyperglycemic levels. So there is a huge fear of using insulin, but at this particular time, insulin has to be the one to be treated, and that is the only way to go. And another question I would want to ask is, it is difficult for everybody to get MRI. Do you think that people can get just an X-ray, sinus X-ray? Will that pick it up early on if they have
no.
Positive?
No, madam.
No.
The X-rays never will. You need a CT scan and an MRI.
Yeah. Okay.
So even if you saw my case where there was no indication of any bone involvement, even on a CT scan, and that's a very early case which we detected on the MRI, and we went ahead and did this. Only the alveolectomy, which is not, considering the disease, it is not much of the morbidity to remove that small portion of the alveolus so that it doesn't spread out. I don't think you can detect on the X-ray.
Okay. So when anybody has these symptoms, it's really important to get an MRI. No X-rays. X-rays are not going to be enough. Thank you. Thank you for that. Dr. Soumitra, could we move on to our last?
Yeah, so I'll quickly push through this case and go to the last case. So this was again a 50-year-old female. The only important thing about this patient was when she came to us, her acetone was 20.
Do you have a slide for that?
I have a, pardon?
You have a slide? We can ask.
Next slide, please. So she had diabetic ketoacidosis. She had diffuse disease. As you can see, again, we couldn't operate her immediately because we had to correct the acetone first, which took us about 9 days. Next slide, please. So we put her on amphotericin. This is what she looked like. This was when I put the endoscope in. This was what it was. You can just make out. Next.
So all the black tissue.
All that black tissue is fungus. There was septal perforation. The septum was completely destroyed. This was how the nose looked like. The nose is looks very nice, actually. This was how it looked like. Next. So we cleared the disease again. Next, please. And this is what the eventual picture is. This is the orbit on the right, the skull base down. There was no septum. The septum's completely gone. The good positive thing is the patient's now 21 days post her amphotericin. She's finished her 21 days of amphotericin. She's still on insulin for her diabetes, which probably we've told her may last for life. But again, no morbidities, no problem. She's doing well, has gone home completely. We'll do an MRI 3 months later, and hopefully things should be great for her. Next, please. But things are not always as rosy. So we had this patient who's a 51-year-old male, again a diabetic, has diabetic ketoacidosis, had COVID 2 months back, was unfortunately operated twice and was given 24 doses of amphotericin also. The relatives came to meet us because the complaints persisted. The palate was removed. We did an MRI and CT scan again, which confirmed residual disease. So it was probably too traumatic for the patient because he already had 2 surgeries, has been given more than enough doses of amphotericin, but still had a feeding tube. Next. And this was what his CT scan looked like. The septum was gone, the palate is gone, but there's still disease in the sphenoid sinus, in the maxilla, in the zygoma. Next. This was how the nose looked like. Most of the turbinates and all the normal anatomy was completely removed, but there was persistent disease in all the sinuses. Next, it's a video. Can you play that video, please?
Thank you so much for sharing all this. The price.
Yeah. Can you play the entire video?
Actually, there's a lag. I think there seems to be a lag on the video.
Yeah.
By the time you're able to view it, we are able to view the video.
Okay, can you play that?
Yes, he's playing it.
Now, what do you show? Because this patient had active CSF coming out, and if I was pressing the orbit, and you could see pus and fungus coming out from the orbit. If you can play it.
It is playing?
Yep, I'm playing, yeah.
And we are able to see it playing.
No, this is the first video. Play the second video, Prem. This is the first video.
Sure. Yep.
Not this one, the second one. No, 2. Mucor 2, please.
Yeah, okay. Previous one is Mucor 2, Doctor.
Yeah, just play Mucor 2.
Yeah, this is Mucor 2. It's already playing.
Okay, yeah, play.
Claim there's a lag, so they're not able to see.
So there was CSF. Yeah, there was a CSF leak. Then, if you can appreciate, this is the orbit, and there's all fungus. See, I've pressed the orbit. This is fungus coming out from the orbit. This is orbital fat, and from there we've removed all the fungus. So again, till you do not remove all the disease, these patients, even if you give them 50 amphotericins, they'll not do well. Next, please. Play the Mucor 3.
Yep, this is Mucor 3.
Okay, so then we had completely removed the disease, we decompressed the orbit, sealed the CSF, the patient's still in the hospital, and hopefully he should be fine.
So the takeaway from this case is, 1, the patient was operated twice already. I mean, it's kind of unfortunate for the patient. And he had 24 doses of amphotericin. Still, it was not enough, or it could not take care of the problem because of the recurrence. And you see the fluid from the brain is leaking. So in simple terms, you put a patch there and cleared up the area.
Yeah. We cleared the area, we sealed the CSF, repaired it, and again, we put in amphotericin.
We are able to see the leak, little bubbles which are coming out. That's the fluid from the brain.
Yeah. Nehal, you have one more case?
Sure.
Next slide, Prem. Next. Yeah, here's one more case.
Dr. Patel, you're on mute, please.
Yeah, sorry. So this is a more advanced case where including the soft tissue is involved. So I think we'll just talk directly on the case. Can you go forward, Prem? So when they reported to us, I think go forward. It's okay. Yeah, press. Yeah. So this patient, he came with the extensive disease involving the entire one side of the maxilla and including the soft palate and hard tissue. And he reported he was under severe ketoacidosis, and that may be the reason disease has spread very fast. Now, these are the cases which require tremendous attention from our side, because this tissue, when we remove, it is difficult to close it. And as Dr. Soumitra said, first thing he does always is he does his endoscopy and try to remove everything from the frontal sphenoid sinus and the ethmoid sinus, and then I come and remove the necrotic part which is visible. So move forward.
This is the last one.
Yeah, I think that. So these are the cases.
It has.
Just press a forward arrow on the keypad and see.
Yep.
Yeah. So when I removed the maxilla, you can see that there is a complete necrosis of the nasal mucosa also. We ended up removing the entire, this is the second drilling, we removed the entire necrosed part till the, sphenoid bone. Go press next. And the only thing we have to do is in this patient is do a daily tracing, amphotericin. If we leave this patient, then what happens is they eventually turn up with the secondaries or recurrence. And daily tracing with the amphotericin, almost 45 days, and this patient he healed well. This is my first wave case actually. We did it in February. Let's go on the last slide. Just press the forward. Yeah, no, it's okay. So I had a follow-up photo of almost 4 months later where you can see the defect has been healed well with the complete epithelialization of the entire area. And now there is a small defect which can be closed with either obturator or something else. So the idea is when you see the mucor, it's like a multidisciplinary, as Dr. Samitra already said. We need to reduce the surgical stress on the patient, and that's where we usually work together. So whenever he says you need to open the maxilla and see what's going on, I usually come in and open the maxilla. Thank you.
Thank you so much. Thank you so much, Dr. Soumitra and Dr. Patel.
Thank you.
So going back to the previous case, we were talking about the patient who had the mucor surgery twice already, and then on 24 doses of amphotericin. Did you have any complications? I think this question I'm going to give it to Dr. Deepta to just say a few words on amphotericin B. What is it, and any side effects? Because the patient has taken so many doses already?
Amphotericin B, originally available as just plain amphotericin B, which is the deoxycholate one, which is the one we used for many, many years. And of course, just because the medicine is in the bloodstream, it diffuses into all different areas of the body. So it used to give rise to, in fact, the infusion, I don't want to make a joke out of it, but my residents used to say amphotericin B infusion. They say, what do you mean, ampho kill? That is how they were so bad. And the first infusion, we used to give a test dose because they all had fever and chills. Then we decided there is no time for us to escalate. So the disease is aggressive. So in most of the cases where there's fungal infection, we start the amphotericin B, the maximum dose we want right the first time. The infusion itself causes fever, chills, and rigors, and body ache, all of that issue. So, but that can be taken care of with the antihistamines and painkillers and paracetamol or Tylenol. We usually pre-dose them, in fact, thinking that they probably will have it. But continued amphotericin B, not the pegylated one, but the regular amphotericin B, which I think is probably what they are using because they are giving daily infusion, because the pegylated one can be given every 3 days or once a week, and penetrates into bone marrow, liver. So you get bone marrow suppression, anemia, it causes hemolysis, and it causes almost everybody has some creatinine increase because of the tubular changes. And then, of course, related to that, you can get distal tubular acidosis, all of that complications related to that. So amphotericin B has to be given in a setting where it is given intravenously. Of course, now the local infusions we are talking about, in the only other area I know of was in bladder, but I'm sure they probably did that even in local tissue necrosis. You could probably give some. And it does penetrate from there too, but the amount of penetration is very little, which is the bloodstream. So when a patient is on amphotericin B, You need to have electrolytes monitored. You need to have blood count monitored. And somebody has to watch the patient. And of course, the fever, we tend to do it with the central venous catheter because amphotericin B is very corrosive for the venous peripheral veins and it causes thrombosis. It's very painful and you get local necrosis and all that because of the infiltration. And that fever from the catheter sepsis is another big issue. So we tend to sort of keep doing blood cultures, but most of the time it's negative. But after the first week, somehow or other, the fever seems to subside. People tolerate it. Surprisingly, amphotericin B, with all of its difficulties, people do take them. They've treated many cryptococcal meningitis in AIDS patients with amphotericin B and regularly, and then till then we do a spinal tap follow-up. So it is unfortunate, but it is a difficult drug, but life-saving drug. The liposomal amphotericin B has much less side effect, 30% of what the regular amphotericin B is. And it is expensive, but the cost is favorable if you look at the side effect on the penetration into tissues. It is penetrates mainly into the infected areas because it's carried by macrophages and goes through the reticuloendothelial system. So it is deposited in infected areas more so rather than everywhere else. So I think that is the biggest advantage of the liposomal amphotericin B. Even the fever, all of it is much less, the renal failure. So for a long run, that will be the best option. But I think the problem is the expense, availability. Even amphotericin B, in spite of all what we have here in our country, during the AIDS epidemic when we used to run short of amphotericin B. And only towards the end of the AIDS epidemic, the liposomal came along only because of the use of the necessity for amphotericin B. And of course, we never had any oral medications before. Now we have posaconazole, which is, I think, Prem, if you want to put on that slide, I just want to go over the two. Anyway, that's about the amphotericin.
Yep. Let me take that.
Yeah. And somebody, you have to have a good internist, an infectious disease person, or a nephrologist with you all the time to follow up. And the doses have to be adjusted for creatinine clearance. So you need to do the clearance on these patients fairly on a regular basis every few days to follow up on that one. So
while the slides are coming up, Dr. Shah, did your patient get M4B? They already got 24 doses. Did they get after the surgery, after they came and saw you?
We have put him on M4B as of now. We are waiting for the histopath report to come. She'll come down tomorrow. Just to also answer that, maybe we actually have been giving the simple conventional amphotericin to our patients. Of all the patients that we've done, only 2 have been given liposomal because both were CRF patients, chronic renal failure. 2 reasons. One, the cost factor. Most of these patients, to understand, have burned their pockets in the COVID treatment. So they've spent probably 20-25 days in ICUs and hospitals and have then come back with mucor. So spending roughly 10 times of what a normal amphotericin costs is something which they'll never do. And the risk is that if we just tell them to have the liposomal, they might not take anything and they will worsen. But touch wood, we've got patients who've come to us very early, and thankfully the conventionals has worked. Obviously, as Madam said, we have had days when we have stopped the amphotericin for creatinine clearance. There's a nephrologist who works round the clock and checks them every day. But yes, we're very happy to say that we've used conventional amphotericin as compared to what probably 80% of people in this country are doing, and have also managed to save their lives with that itself. We've had issues with creatinine in a couple of patients. We've had issues of fever, rigors, loss of appetite, but that's small compared to what, if you look at the bigger picture, 20 days later on, they are fine, they are better. So yeah, we work primarily with the conventional amphotericins only.
Thank you. Thank you so much. You are doing a great job, commendable job to all of you. My other question is availability an issue of the liposomal amphotericin B in India now?
It was, but now the government started sourcing them. So now what's happened? Initially, it could be purchased from any pharmacy, and there were issues with black marketing and people stocking it up. But now the government's got proactive, so now every hospital sends its list of patients to the government, and we get it from a government hospital every day. So if you ask for probably 15 vials, you get 10, but yeah, it's getting better. So the issue of non-availability is not there anymore.
Okay, that's good to know. That's good. Thank
And
you.
I do have to concur with what you say. In spite of liposomal amphotericin B available even in this country, for a period of time, we could not give them because even though patients in the United States have insurance of some type or other, the cost was a big issue. So many of the insurance companies used to deny us unless we were able to show that the conventional amphotericin B did not or had problems. So, but there is extensive literature in use of conventional amphotericin B. So I think the history is in your side, and you can manage it and you can adjust it. And it is, I think what you're doing is the right way to go in an area where the disease is aggressive, and it's you need to have handle on it. You need to get something in, and which is very it's also is favorable for the patient. And you have enormous amount of experience in amphotericin B all over the world with the conventional one. So I think it is that is probably the right way to do what you're doing. And I want to ask one more question. Are you giving posaconazole as a follow-up, or are you using it at all?
You're using
it as step-down therapy.
Okay.
You're using it as step-down therapy.
Is that very expensive also?
Yes.
Yes.
Not.
Yes,
Yes.
Okay. So I have
one question. I have one question, Deepta, if you don't mind.
Yeah.
So, say we see a lot of cases where patient come with amphotericin treatment. Say this patient, there's one more patient where the treatment was done. Now there is a sequestra formation. I mean, on radiograph, you can see there is a separated bone from the healthy bone. That means chronic disease. Patient has finished his entire ampho treatment, and if we do surgery, if we remove that osteomyelitic or necrotic bone, say if 5% chance or 10% chance in that necrotic bone, if it comes out to be a mucor, do we have to repeat the dose, or otherwise, since the disease has been stagnant, it is a sequestered bone which has been separated from the body, and body is trying to extrude that bone out of the body. We can just keep that patient on the observation without delivering the amphotericin again?
I think what you're saying is absolutely true, because mucormycosis in this particular condition, in this area, it's a locally invasive disease. It's not a systemic disease. So when you are in regular osteomyelitis, it's usually a bloodstream infection. It's not a locally invasive. So there we continue to give antibiotics and others. In mucor and most of the fungal infection, it is local therapies what is needed. So I think if you remove the bone on a patient who's already has been on amphotericin B, that should be fine. And amphotericin B has a long half-life, and it is present in your system for even up to 1 to 2 weeks in smaller quantities. Because that is why even after you stop therapy on amphotericin B, they can come back up to 15 days to a month with the renal issues. So I would suggest that when you have completed a therapy, you can remove the bone. And if you're anxious about it, you might want to start them on an oral antifungal therapy. And that might be able to give you that backup, what you're looking for, because all you're looking to see is whether you are you want to suppress any underlying fungus which is around there, which is of a minimal quantity. So, and another thing you have to understand, penetration into the bone of any antifungals or antimicrobials is really is very limited. So even after you remove the bone, if there is other areas, if you have good immunity on the patient, and if your diabetes is controlled, you become like the normal person who we are, who can control the mucormycosis by just our T cell and B cell function. So local therapy, controlled amphotericin B follow-up, and continued debridement as you go on.
So
Thank you.
Thank you so much for that. I think we are coming to 1.5 hours already, but I do want to ask one thing to Dr. Shah. There's a question from Dr. Raja, and his question is regarding the role of laser in this whole process, laser therapy.
No, I don't think so, madam, because in this case, as I said, we are more aggressive than what we normally are as endoscopic sinus surgeons. So we are trying to debride every piece of tissue. So the laser is not really required. We have debriders which help us shave these mucosa off and shave the bone off. So no, lasers are not going to really per se give us a more advantage or something of that sort in this case, no.
Okay. So what would be the take-home points other than, I'll let you discuss the take-home points. Dr. Deepta, any take-home points?
I think the take-home point is on this is it's a very unusual disease. Just like how COVID is something which we never expected and how it has become progressive. This is another unusual fungus, and it has taken off for some unknown reason in India. The only way we can advise everybody and ourselves to take care of it is find out if you're a diabetic or if you're hyperglycemic. Control your sugars. This is probably a time where everybody should get your sugar checked and a hemoglobin A1C as a part of routine, which we normally do here, and get that done and get your sugars controlled. On COVID patients, physicians who are giving them steroids need to be steroids and as well as immunomodulators need to be aggressive with their control of hyperglycemia with insulin. And that is one of the things we need to do. And educate the public that diabetes is not I have to say that somehow or other people have accepted even cancer, but they don't want to accept diabetes. There seems to carry a lot of bias with that. It is we can be well controlled, and insulin is not your enemy. Insulin is the helper at this point of time. And after insulin therapy, after maybe, as the physician said, 1 or 2 years later, or maybe 6 months down the road, if you can control it, you might be able to get on with oral hypoglycemics, because this is just an aggressive area at this point. And if you're going to be doing inhalation at home, please use completely boiled water. Boil it so that the fungus will be resolved, or if you can get bottled sterilized water and keep it in the refrigerator and take small quantity, and all the equipments which you use should, if you can, sterilize them like what you do for equipments. Sterilize them and use them, because we are not sure where it is coming from. If that is one area, we could at least control that. Do not use tap water. Do not use water left outside for a period of time. And you consume goods which have fungal spore on it, like all those black molds and everything else. Get rid of them, because taking them in your hand and looking at them, the spores coming. So keep your fruits and vegetables, all the other areas, as sterile as possible. Get rid of all of the things which are necrotic in the house. Throw them all out. And with the COVID vaccination, that is the only way we're going to control the disease. Everybody, please get vaccinated. With the vaccination, the COVID disease will go down. With that, we will come out of this phase, and we will not be able to see this black fungus again for a long period of time. So we'll go back to the normality of where the black fungus was, just like the physician said, about 3 to 6 cases per year.
Thank you, Dr. Deepta. Thank you so much. Dr. Shah, any take-home points? closing statements?
It's what the take-home points, as like Dr. Lee mentioned. First thing, if you've got COVID, you're cured of COVID, don't forget to control your diabetes. That's paramount. Control your sugar. Accept that you have diabetes. Control it. That's what we tell here to our patients, is that anybody who's had COVID and in the next 3 months, if you have headache or facial pain, don't take it lightly. Go see your doctor if he wants. Get yourself imaged. Check it. If it's there, it will be cured. If there's nothing wrong, great. But don't ignore the symptoms. Stay safe and be aware of your problems, and just go and consult a doctor.
Thank you. Thank you. Very well said. Thank you so
much. Because as you saw, in our series, we are very happy and proud. Touchwood, till date, we have only had one patient where we removed the eye. We've not removed an eyeball till date, except for one patient. So if they come to us on time, we'll be able to treat them very well. So rather than being scared of the disease, don't get scared. Just go and visit your doctor.
Right. Just like your first patient, the 20-year-old girl who was in the initial stages.
Yeah.
Thank you. Thank you for that. Thank you very much. Dr. Patel, any take-home points, closing statements?
Yeah, I think he already summarized well whatever we are doing. And as he said, the early detection is a key to cure for this disease. And
Thank you. Thank you so much for that. So I want to take 30 seconds. The first thing is, just like pulse oximeters have become a norm in every household, I think the glucometer should become a norm in every household these days. It's really important. Anybody who has COVID, doesn't matter what their sugars have been in the past, they should get a fasting finger prick. Please do the fasting finger prick. That's one thing I wanted to say. And as Dr. Deepta was saying, also a hemoglobin A1C would definitely help to be able to control your sugars, and also if you're on steroids, to be able to actually adjust your glucose medications, your insulin medications accordingly. That's one thing I want to tell. The second thing, what I've learned is early treatment, early recognition and prompt treatment. So anytime you have COVID, 4 weeks, 6 weeks, or anytime post-COVID, if you have headache, facial pain, watery eyes, swelling, and you feel the jaw is hurting, please see the doctor or do a televisit and get your imaging done. And prompt early recognition is very, very important. That's the key. And then later on, once the ENT surgeon, your primary care or ENT surgeon sees you, then they will take care of what needs to be done after that. So those are the main points that I wanted to just convey as a team. I'd like to invite Prem to talk about COVID-19 Tamil Task Team. Prem?
Hi, good morning and good evening to all. So I'm Prem, from one of the volunteers from COVID-19 Tamil Task Team. We started this task team on last year during our US pandemic thing. Dr. Saravanan from Atma, Governor, along with that, Mr. Mahendran from Pennsylvania, Mr. Dayanand from Delaware State, and Mani from New Jersey State. The four of them initiated this COVID-19 Tamil Task Team, and we had many volunteers working on many teams from on 24/7 clock, from help desk ticket, and we having follow-up team, and we having a prescription team, and we having a IT team, and we having some set of people who coordinating with our doctors, and we almost closed around 5,000 ticket last year, and we served our US people, and now we having a offshore team to support our Indian people, and we having a separate team in India who's taking care on our during their working hours, and on non-working hours we are taking from our team. And currently in our India situation, many things happening, and we are providing support to route our people to have some bed, and those who need oxygen concentrator, or those need some direction, which some team they daily they are making the particular they're reaching the particular hospital to know what are the availability, and if they need any medicine, how to reach, to whom to reach. And we reaching the patient and their friends and neighbors to route to the particular place, and what kind of treatment they need to do. And we having a doctor's team who guiding a lot. So anyone need any support from India, you can free to send an email to covid-teamindia@gmail.com, and we are ready to support. Thank you very much to all the volunteers and doctors for helping this.
Thank you. Prem, you've been a great support. He's the IT brain of the team. So he puts all the flyers, does everything, working late hours. So we really appreciate your help. Thank you so much for doing that. The email ID is COVID-19 taskteamindia@gmail.com. Any questions you have, anything, you need any kind of help, please send us an email to that. We would be really, we'll try our best to help out. Thank you. And I do want to thank Dr. Saravanan. He's here as well. Dr. Saravanan, he's the main driving force behind all these webinars and also the COVID-19 Tamil Task team. So Dr. Saravanan.
Thank you, Dr. Mupana and Dr. Deepta, Dr. Shah, and other experts. And sorry?
Dr. Patel.
Dr. Patel, Neha Patel. I have a friend, my wife has a friend, Neha Patel. Excellent presentation. It's eye-opener. I mean, I'm planning to edit this video and send it to my hospital. I don't think, like Dr. Deepta said, in United States, we don't see this much mucor, at the same time. This is a rich experience. It has to be shared to all over the world. I think it's excellent presentation. I don't have anything else to say. And I'm very thankful for whatever we're doing. At American Tamil Medical Association, Dr. Deepta was past president. And Dr. Mupana is a member now, and there are other physicians here. I think Dr. Einstein was here. I believe Dr. Present President. American Tamil Medical Association helps a lot. We recently sent medical supplies, oxygen concentrator, as well as what Prem says. We have a team of at least 140 people, at least actively 40-50 people, 24/7 helping the people on the ground. Okay, we always believe in that. With that, I close my remarks, and thank you very much for everything, doctors. Thank you.
Thank you.
I just want to say one final word. Yeah. I want to thank the physician. As well as the government, because there's a lot of governmental issues there too, and also lack of supplies for so many things, and the weather is not that conducive, especially during the summer months. I really, hats off to them. They are working under a strenuous condition, and I'm amazed at their commitment and continued commitment and working at that. I pray that all of you do very well, and the situation improves, and you will all come out of this very well. I am really, really, absolutely amazed, and I'm always in support of the people who are working so hard. It is easier to work in a very developed country like us. Things are available, but situation in India at this point is so bad. I am just thankful and cannot believe how aggressively people are following up and having such successful results like what they have done in here. So thank you, Dr. Patel, and thank you, Dr. Shah. And please convey it to all of your friends how we are here. And every one of the people, every one of the physicians or the public in the United States talk about India. I go to country club, my tennis players, and everybody say, Deepta, how are they doing? How is it? My God, I hope everything gets better. That is the kind of the discussion is there. And public support with both finance and others are also there. So, and thank you all very much. God bless all of you. Thank you.
Thank you.
I would like to thank Dr. Deepta, Dr. Patel, and Dr. Shah. The videos, they're priceless. I think even if we go anywhere, we won't be able to just to look at them. It felt as though we were actually seeing those cases. So we really appreciate you for that. We are very grateful for sharing those videos and the pictures and the discussing about the clinical cases. And anything that we could do for you, please do let us know. Again, Sorry?
We will.
I know. Can I say it publicly?
Yeah, forget it. Don't.
Okay. So anything. It's COVID-19 India task team. COVID-19 task team India @gmail.com. Again, COVID-19 task team India @gmail.com. So please send us an email. There's one last question from the audience. Is there a role for douche? And the
nasal douche. Yeah, the nasal douche. We do it 15 days after surgery. We recommend to do it for 2 months, 15 days after the surgery.
15 days
for 2
after
months.
Surgery. Okay.
Yeah, for 2 months.
For 2 months?
Yeah.
For 2 months. Okay. And there's one question for Dr. Deepta. If you can keep it short, we really appreciate that. Onions and black fungus.
Onions and black fungus. I mean, the fungus which you see on all of them, and I think they are the fungus, but I don't know anything separate about the onion and black fungus. Is there something?
So they said Manisha asked, black mold on onions, is it harmful, doctor?
I think at this point, mold on everywhere is harmful because the spores. So we didn't care before. So if you're a diabetic, be careful about it, throw it out, or go to the other side and cut it out and throw it if you can. I would throw out every piece of vegetable which has fungus in it. Or if you want to use it, wear a proper mask and then cut the spore out, that area, and use the other one. So all spores, because the other one is aspergillus, which is also so problematic. All these things are there if you're immunocompromised. Healthy people, it's okay.
Right. Thank you, everybody. Dr. Saranan, you was about to say something?
Yeah, so Dr. Shah, please reach out to us. I mean,
thank you.
Anything we can help. I mean, if anything we can do. You guys are doing great service, as Dr. Deepta says. I mean, we are kind of a little bit, to say, sitting in a comfortable environment, extremely working. I mean, I did my medical school, residency, everything from Stanley Medical College, government hospital setup, government is providing a lot of stuff, but the population is huge.